Good morning, everyone. I hope all of you had a wonderful Deepavali and many other festivals, Govardhan Puja and Bhai Dooj. So welcome to ISG Masterclass in yet another edition. Last 1 week, we did not do Masterclass because of festival. So our apology for that. Now we have one other Masterclass today, and this is one of the very important topics, which is favorite of all gastroenterologists, that how do you approach a patient who had a obstructive jaundice or extrahepatic biliary obstruction. And this is one of the very important topic. You see these patients every day in your outpatient, not only outpatient, but also this is one of the very favorite topic in the examination. I think all of you will get one case of extrahepatic biliary obstruction out of 3 or 4 as per institution rule in your DM or DNB exit examination. So to focus on this topic, we thought we must have one masterclass on this very important topic. How do you differentiate? How do you approach? How do you investigate these patients and the planning of management? So to do that, today we have 3 very eminent faculty of our country, including Dr. S.P. Misra. We all know Dr. S.P. Misra is a professor and head of gastroenterology at Motilal Nehru Institute or hospital in Allahabad, and he had been the Secretary General of ISG. He had been the President of ISG. We have welcome Dr. Misra. We have Dr. Vivek Saraswat, and all of us know that Dr. Saraswat has been a head of gastroenterology at SGPGI Lucknow, but after completing his tenure there at SGPGI, now he moved to Jaipur, and presently he is the director of Department of Gastroenterology at Mahatma Gandhi Institute, Mahatma Gandhi Hospital, Medical College and Hospital at Jaipur. And he had been the president of INAZL and ISG, very astute teacher. So welcome, Dr. Saraswat. Dr. Saraswat is traveling, and look at his passion. He's at this point of the airport and still joining because of some change in flight, so the timing was changed. But he will join for some time and probably he will have to leave in between the case. We have Dr. Manu Tandon, and we know that Manu Tandon is one of the top class teacher and Dr. Manu Tandon is at the AIG Hyderabad. We all know all our faculty members, and this week the case has come from AIG Hyderabad. So may I request Dr. Manu Tandon to introduce both the students. And before we do that, we have for today's masterclass facilitator is Dr. Manas Panigrahi. Manas Panigrahi is a very dynamic, and I would say star person. He is at AIIMS Bhubaneswar, and he's associate professor. So he will run the case today and help us in conducting this masterclass. Over to all the faculty members, but first to Dr. Tandon to introduce two of the students. And all please write your questions on the chat box, and all the faculty will try to take all these questions in the masterclass. Over to all the faculty. Dr. Tandon, please.
Thanks, Govind. And I think on behalf of the entire faculty, Vivek, as he told, is going to leave us a little shortly for reasons beyond his control. This boarding time is nearing. SP Mishra is there, Manas is there. We would like to thank you for giving us this privilege. And I, on behalf of the Asian Institute, am grateful that ISG has given an opportunity to our residents. We have 2 residents, both of them in their final year. They'll be taking their exam in the coming year. Dr. Maharishi and Dr. Adesh, both of them you can spot on the same screen. We have 2 hospitals of AIG. They are sitting in the library of the newer building, and from which they will present their cases, which will be monitored through Dr. Manas. This, as Govind has already told you, is a case of extrahepatic biliary obstructions. And between the 3 of us and Manas, we will try our best to clarify things as the case proceeds. So we are ready, and we are ready to start on. Manas, you would like to say something, or you straight away hand over to the registrars?
Straight away, I will show the presentation, share the slides, sir, and hand over to the registrar. The slides are visible.
Yes, sir. Good morning, everyone. Myself, Dr. Satya Maharshi. I am going to present about clinical history of this case.
Go ahead, Satya. Go ahead.
Next slide. Yes. It is not moving. Just a minute. Let me
load again, please, Manas.
Okay, okay, sir. Just I'm stopping sharing and again I am sharing.
Don't worry. Load again.
Yeah. Is it visible, sir?
Yes, yes.
Yes,
He
yes.
is a 42
Dr. Maharshi, please go ahead.
He's a 42-year-old gentleman, resident of Assam, who is a health counselor, studied up to graduation. History is informant himself, sir, which is reliable. Admitted to our hospital with chief complaints of yellowish discoloration of eyes and skin since 6 weeks and generalized itching since 5 weeks.
Next slide. I'm not seeing the next slide, please, Maharshi. Yeah. Move, yes, now we're on the next slide. Go ahead.
Coming to the history of present illness, patient was apparently asymptomatic 6 weeks ago, sir, when he developed this yellowish discoloration of eyes and skin, which was initially noted by the family members. And this is incidence in onset, gradually progressive to present day, sir. This jaundice is also associated with high colored urine, pale colored stools, and is also associated with generalized itching, sir. This itching is more towards the evening hours, and you can rate it as severity grade 2 to 3, sir, which is interfering with the daily activities and sleep, and is predominantly over extremities and back, sir. Patient also had a history of easy fatigability, and he also gives the history of loss of appetite and weight loss of 7 kgs over 6 weeks. However, he had not given any history of no history of prodrome prior to the onset of jaundice, and there is also no history of alternate medication intake prior to the onset of jaundice, sir. And this jaundice is also not associated with altered sensorium. There is no history of pain abdomen associated with this jaundice. There is no history of abdominal distension or awareness of lump abdomen, and there is no history of hematemesis or melena. No, there is no history of fever and night sweats. We asked the history of any history of passage of oily stools or difficulty in flushing stool. However, there is no history. There is no history of joint pain, skin rashes, flushing or episodic wheeze, and there is no history of polyuria or polydipsia, and there is no history of altered bowel habits or blood in stools. There is no history of shortness of breath and decreased urine output. There is no history of tattooing or blood transfusion. Coming to the past history, is a known case of hypertensive on regular medication. However, there is no history of similar complaints of jaundice in the past and no history of surgeries. Coming to the treatment history, he was evaluated in Assam Medical College for which with the history of jaundice, and for which he was advised blood investigations, ultrasound abdomen, and followed by MRI with MRCP, which we will discuss in the later slides. And he was managed conservatively, sir. And he was not on any prolonged medications except for tablet telmisartan 20 mg once daily for 2 years, and there is no history of any endoscopic interventions. Coming to the personal history, he denies history of alcohol consumption or smoking. He takes mixed diet. Currently, he was taking 1200 kilocalories per day, sir, with deficit of 800 kilocalories per day. And protein intake, he was taking 30 grams per day with a deficit of 35 grams per day, according to his weight of 65 to 66 kg. No history of high risk behavior. Coming to the family history, there are no similar complaints in the family, no history of gallstones or any. There is no history of any other malignancy in the family, and father expired at the age of 72 with natural cause. Pedigree, however, the born to a non-consanguineous marriage, none of the family members are affected, sir. To summarize my case, this is a 42-year-old male who is a known case of with comorbidities of hypertension without any addictions, presented with insidious onset, painless, progressive jaundice with generalized pruritus, pale colored stools, and significant weight loss since 6 weeks in the absence of prodromal symptoms with ECOG performance status of 0, sir.
So, sir, with the poll question. So this is 42-year male with history of painless progressive jaundice and weight loss. These are the 4 options. Let's see how our audience is responding. So our poll results are, most of the audience are gone with cholangiocarcinoma, 45%, and then ampullary carcinoma, 25%, and then carcinoma hyoidopancreas, that is 23%, and carcinoma GB, that is 8%. So,
Now, Manas, before we go on with this poll, and I think they have a few basic things that I'd like to bring up.
yes, sir, please
Dr.
go.
Maharshi and Dr. Arun both might address it. See, you have already decided it is extrahepatic biliary obstruction.
Yes, sir. Yes, sir.
Sir, please go.
SP, mute. You are
We lost
muted.
that. Can you hear me or what's wrong? Yeah. No, so the question is, how have you ruled out intrahepatic cholestasis on history? We haven't examined the patient. You have taken the history here. So
Sir.
straight away to jump to a differential extrahepatic obstruction, what are the points in this patient by which you say that this is definitely extrahepatic cholestasis and not intrahepatic cholestasis?
Manas,
It
can you
is
go back?
painless.
Can you
It is-
go back a slide, please?
Yes, sir. Yes.
His slide. This was your poll question.
Yes, sir.
Please,
So
like
summary. Can you go back to summary, please?
summary, yeah.
Yes, sir.
So basically, it's painless progressive jaundice. There is no fever. There is no history of cholangitis, no surgery, no interventions. So
No
no
prodrome
hard
also.
pointer in favor.
Vivek,
prodrome.
Yes, absence of
Vivek, he did not put his neck out. It was Manas who came to the poll question. He has not told you the diagnosis yet.
No, that's fine. I think this is for the benefit of the audience, that when you have a history, what you have is jaundice. You have cholestatic jaundice because there is itching, there is pruritus, pale stools. But maybe somebody can recap what are the typical differentiating points.
Yes, sir. The intrahepatic cholestasis, there will be history of prodrome, sir, or any history of drug intake, or any other similar history in the family, sir, which are not there in this case. There are no prodromal symptoms, no history of any drug intake or CAM, and no similar history in the families.
No, you can have an intrahepatic malignancy.
Nice. Intrahepatic malignancy,
extrahepatic
painless, sir. This is a painless jaundice. Intrahepatic malignancy can have painful, sir.
No, just
intrahepatic
on
is
the basis
painless.
of pain, you can't say.
You can't have, not necessary, you may have pain in intrahepatic malignancies.
Yes.
Jayanti has said a question on granulomatous disorders also may present like this.
I think before we take the audience polls, Manu, before we start with the audience questions, maybe just let's complete the learning points here for
Yes.
intrahepatic cholestasis versus extrahepatic. If there is pain.
So Satya, one thing is clear that once you have a patient like this, just on the basis of history, you cannot rule out intrahepatic causes.
Yeah.
And only thing is, if you have prodrome and all those things, then you can go with that. And the weight loss is much better. So you have to reason out why you think this is extrahepatic and not intrahepatic. So you better reason it out then. You have reasons for it?
Absence of prodromal symptoms, sir.
Okay.
No history of intake of CAM, any alternative medication.
Good.
The progressive weight loss, sir. There's a significant weight loss.
I would point out that there is, you have not taken a very adequate history of drug intake. See, you have said no CAM. Now, CAM is not the only drug that causes cholestatic jaundice. Most often, you have allopathic medicines and a history of ingestion of drugs that could have caused cholestasis. Antibiotics like clavulanic acid, then you would have antimicrobials, antifungals, steroids, anabolic steroids. There's a long list of drugs that cause large-actil neurosedatives and antiepileptics that can cause cholestasis. So we have not heard the history of absence of these illnesses.
Vivek, can I just put in? I think we're jumping the gun. Satya, what's your diagnosis now? After summary,
You give your diagnosis and support it with whatever you have said so far in the history. That's what SP wants.
So this is your diagnosis.
Yes.
Satya?
Obstructive jaundice. Manas, can we remove this this slide?
Which one, sir?
Just cut it.
The present slide. Let him go back to his summary and make a call.
Sir. Yes, sir.
This there's a slide on the top also, polling question. It's
so you just cut it out. So just cut it out, sir. Just cancel that. The crossover of that is
yeah. Thank you. Yeah. Now Maharishi.
So if you can make a point out here, the Commissioner can make a point out here. See this patient, 42 years with 6 weeks history. It will be very difficult to exclude intrahepatic cause. Yes. So absence of prodrome or absence of drug history does not exclude, because at 42
points but does not exclude. Even I agree with that. You keep both options open.
So to all the residents, see, absence of sign does not mean absence of disease, right? So absence of prodrome just tells you there's no viral hepatitis. Again, but 30% of AVH do not have classical prodrome. So absence of signs should not always restrict you from a diagnosis. So keep a broad perspective of both intra and extrahepatic. Certainly you can always choose that the intrahepatic is my first etiology or first syndromic diagnosis, or extrahepatic my first syndromic diagnosis. So it's good to be broad.
I think relatively a soft point here could be that there is a very short interval between onset of jaundice and appearance of pruritus, which is very intense. The high-grade severe pruritus coming so soon after the appearance of jaundice does argue for complete obstruction, which is generally extrahepatic, number one. And number two, if you take 10 patients of cholestatic jaundice, probably 7, 8 of them will have extrahepatic cholestasis and only 1 or 2 will have intrahepatic cholestasis. So these are relatively soft points that tell you that this is likely to be extrahepatic cholestasis, but you are not able to rule out intrahepatic cholestasis completely, and intrahepatic primarily drug-related. Now, drugs, you have said no history of prolonged ingestion of drugs, but there can be drugs like somebody, not in this patient, but say otherwise if there's somebody is taking, say, anabolic steroids. Today, a lot of people go to gyms and take bodybuilding medicines, or they take some medications that their trainer gives them, and they create problems. So they may or may not, unless you specifically dig for these points, you may find that ingestion of anabolic steroids, ingestion of oral contraceptives, and other drugs, not necessarily over a prolonged period, may have been overlooked. So one needs to bear that in mind, and that may come as a lower down problem. But overall, as I said, the very short interval between deep significant jaundice and intense pruritus argues for extrahepatic obstruction, as well as the fact that numerically or statistically, extrahepatic cholestasis is definitely commoner than intrahepatic cholestasis. I thought that was worth mentioning here, because when you have cholestatic jaundice, the first differentiation is intrahepatic versus extrahepatic. Then in extrahepatic, benign or malignant. In malignant, upper end block or lower end block, and that way you can systematically proceed to differentiate and reach your point. So maybe now we can go ahead with your differential.
So the learning point over here is that on history, unless and until the patient complains of mass, it's very difficult to differentiate between the two.
Yes, there is pain, there is cholangitis, presence of a mass, or surgery, or say ERCP.
ERCP or procedure.
All those things would suggest that this could be extrahepatic. In their absence, you are not sure that it is extrahepatic, so you must keep an intrahepatic possibility also. Okay, thank you. Please go ahead.
After this, next.
So this is your differential diagnosis.
Yes, sir.
Now reason out why did you keep number 1 as ampullary carcinoma? Your sequence 1, 2, 3, 4.
Yes, sir. Short history and painless progressive jaundice, sir.
Ampullary is relatively slow growing, I thought.
I mean, Satya, one thing, you are giving this as an alibi for not having intrahepatic cholestasis, that there was no pain. And here you are considering no pain as a possibility for ampullary. You can't have both the things.
See, if you look at extrahepatic cholestasis, gallbladder and pancreas are generally painful, while cholangiocarcinoma and ampullary carcinoma are often painless. So why plumb for ampullary first? Why not cholangiocarcinoma first? What is the
Of
typical
the two,
history on the
which
basis
will
of which you call
produce more
cholangio?
intense jaundice and quite rapid of the two?
So for the teaching purpose,
Ampullary presents early, sir.
go ahead, Chris.
How do you know it's
Okay.
early? It's all short duration. So
I,
what is the typical history which you will make you say this must be ampullary carcinoma?
Cholangitis, sir. Presence of cholangitis.
Number 1. Number 2,
up and down
Vaccine.
jaundice also there?
Fluctuating jaundice.
Yes.
absolutely fluctuations.
Yes, sir.
So cholangitis, fluctuating jaundice, maybe GI bleed.
Yes, sir.
So-called silvery stools, you would have heard, cholestatic stools where there is a
Not
And,
very commonly seen.
typically described.
Vivek, it
But there is
doesn't
no
progress
fluctuation.
so rapidly. It doesn't progress so rapidly. Here it is really progressively worsening.
And
I
so much of
fully agree
weight
with
loss, so much of weight loss.
Yes. So I think ampullary of the two would become a second choice. Anyway,
Yes.
you take a call and give your reasoning.
No, one more thing I want to tell the students. See, he is using a counter argument for not having intrahepatic cholestasis, that there was no pain. And he's using the same argument in the opposite way of saying that it's ampullary carcinoma. You can't have the same argument in a differential diagnosis, that
That is
the
fine.
pain is not there, you can't use it for a. So you stick to it, there's no pain, then this is not a possibility.
Right. So, I mean, your first possibilities, you mentioned you probably would cholangiocarcinoma and ampullary. Now, can carcinoma head of pancreas be painless?
Yes, sir.
Can carcinoma gallbladder be painless?
Yes, sir.
In
30 to
what
40%.
frequency?
30 to
How
40%.
often?
Very good.
40%?
30-40% is pain.
EHBO 70%, 70 to 75% will be painful, sir. 30% will be painless. Carcinoma gallbladder 60 to 70% will be painful and 30 to 40% painless.
Right. So, what is the
Again, this
relative
is for a
frequency
cohort,
of
not for the
condition?
one index patient.
Yes.
Exactly.
Yes.
But in a given, I mean, what is the frequency of distribution of the different causes? Say if it's something is 10% while something is
Yes, sir.
40%, 10% or 40, I mean 30% or 40% might still be more in frequency. So what is your understanding in India? What are the usual common
Yes.
causes of, what is the breakup of these 4 conditions?
In North India, the carcinoma gallbladder is more common, sir, in the Ganges belt. So predominantly the carcinoma gallbladder, followed by pancreatic head cancer, followed by periampullary and cholangio, sir, in North India. Whereas in South India, pancreatic cancer, common, followed by periampullary, followed by cholangio and carcinoma gallbladder.
He's from Northeast.
As he was Northeastern.
Is there any other cause of malignancy that you will consider, Maharishi? You have given 4. I think one more you should add. As a completion of the list, it may not be in this case, since you are listing out. He has no GO, but suppose he had a GO, what would have been the cause?
Carcinoma deep.
No, metastatic lymph nodes we have seen quite often, and the endocrinologist eventually picks it up, you know.
Yes.
Yeah. Metastatic hilar lymph nodes, yes.
Yes, metastatic lymph nodes. Now, suppose you have mentioned GO. So I specifically said, suppose he had a GO, then the commonest cause would be a portal lymph node there at the porta. So to complete your list may not include in this case, and for teaching, 5 causes you should list for malignancy. Elimination one by one we are doing.
Manu, you're right, but GO is also very common with
Yeah, CA pancreas,
Gallbladder.
and gallbladder.
CA GB, CA pancreas, anyone. So a lymph nodal metastasis is a well-known cause of malignant obstruction.
Now, amongst the various causes you mentioned, the order you mentioned, general free sequence, but do you have any published data from any published series from India? There are 4 or 5 from North India, and there are a couple from South India, which give the break.
Yes, sir. We have SGPG experience and on study Vijay Sharma sir regarding this incidents.
Yeah.
Yeah.
Extrahepatic biliary obstruction.
SGPGI and Banaras, there are 3 or 4 cities which give you the breakup.
Yes.
If you're the MP Sharma series, people often quote that's about
Yes.
30% was gallbladder pancreas and 28% is pancreas, while about 20% is cholangiocarcinoma and 16-17% was ampullary carcinoma. So you need to bear that in order, because that also has a bearing on how you will list them. While painless and painful is nice, but when things are very common, the other series which up to 40% are gallbladder carcinoma from North India. And if about 30% of them are painless, then you still would be commoner than ampullary carcinoma. So all these statistics, when you basically don't have clinical pointers, and when you fall back on numbers, then the statistics and the series data is very important. You should be comfortably able to quote those and place your patient in that line.
Vivek, we have not dissected the history basically. Just jump to the differential diagnosis.
Yes, the history examination we haven't talked about.
History also, we haven't dissected the history. We haven't
Also,
talked
I
about
think-
this.
Yeah,
So, Satya, you
loss
said
has
about
been
the protein
emphasized.
intake. How much was the protein intake?
Sir, 30 grams, sir.
And his weight is?
65.
65 to 65. Sir.
So it is 5.5 grams.
Yeah.
And you said it's
Deficiency.
normal. It's not normal then. It should be 0.8 to 1.
He said it was deficient by 30 grams.
Yeah,
Deficient by 30 grams.
Yeah, matlab, putting 1 gram, it should be
Okay, that's fine.
65. We got 35 only.
Good, then that's fine.
I have one basic question, Maharishi. In now, let us assume this extrahepatic obstruction statistic wise, since Vivek asked statistics, how many are overall benign and how many are malignant? I mean, Vivek was just talking about only malignancy. I'm talking in general of extrahepatic obstruction, blind. How many turn out to be malignant statistics wise?
70% were malignant, sir.
Correct. 72 to 75 are malignant and 25 to 28 are benign. Good. Go ahead.
Sorry guys, Manu,
Okay,
SP.
Yeah.
I'll
All
have
the
to
best,
leave.
all the best.
All the
Bye-bye.
best.
See
Safe
you.
travel.
Bye-bye.
Safe travel.
Satyan, what are the benign causes?
Sir, benign causes, okay, biliary strictures, sir. Benign biliary strictures. It can be secondary to chronic
of?
pancreatitis.
Because of what?
Because of chronic pancreatitis or
Hmm.
recurrent cholangitis due to cholelithiasis CBD stone.
Is it cause of
Surgery,
strictures?
post-surgical commonest,
Post-surgical, post-LT,
both
sir.
OLT and lap chole. That's
Yes,
what SP wants.
And PSC?
PSC.
PSC, IgG4, we are beginning to identify
PSC,
more and
IgG4,
more.
chronic pancreatitis leading to distal CBD stricture.
The commonest three, Satya, Maharishi, are post-chole, CP, and then depending on your state, OLT if your center is practicing. Post-OLT. And then you
rarely
get
you can have-
IgG4 and PSC.
Yes. IgG4 and
Okay.
rarely you can have tuberculosis and all those things.
Yeah, TB lymph nodes are very common. Portal cyst, correct? Jayanti has written, I was coming to that. If you are a liver unit, portal hypertensive, portal cavernous, or whatever you want to call it. We used to call it bilopathy. This name is too long. Go ahead. SP, shall we move ahead or what?
I just wanted basically to discuss the symptoms and the history, but we have already passed that. No, man, go ahead, please.
Sir, I'm hand over. Yeah, examination and investigations will be told by Adesh, sir.
Adesh. Okay.
Good morning, everyone. I'll be continuing with the investigations.
Yeah, Adesh, you have heard the questions. What is your order now? After what Vivek and the comments and SP and myself said, what is your order of preferences? And then let's talk over.
Cholangio will be first, sir.
Okay.
Second will be because of painless. He's from east of the India, so GB
Northeast.
painless GB with this thing will be the second according to the
Fine.
this thing. Third would be C ahead of pancreas, and ampullary will be the lowest.
Lowest. Even statistic wise, that is the worst.
But then why
Okay,
cholangio
good.
and why not CHGB first?
Again, I would say I have not examined the patient yet, but still painless GB is most of the cases are painful, sir, and the usually once the jaundice sets in, it's already too advanced. So he would have had a longer duration of this thing symptoms with more significant weight loss.
So
He's
suppose
a
suppose
very
it is the neck. The
sir?
moment the neck is involved, the CBD will be involved.
Yes.
We are seeing
Yeah,
lots of
neck,
patients, and most of them are painless.
yeah,
Detected
neck
by us, not
CHB
by-
with neck in the neck can be a probability here, sir.
If I
Okay,
can a
go ahead,
couple
go
of
ahead.
points, if I can a couple of points, the point number one that although we teach that the fluctuation in perium
It's not
carcinoma
common.
is there,
Yes, sir.
but again, once you look at LFT report, then you can see bilirubin fluctuating from 5 to 6 to 9 to again back to 3 or 4. But clinically, patient will not able to appreciate the fluctuation in his jaundice. But for a patient, very difficult to see that bilirubin is 3 or 5 or 7 or 9, very difficult. So fluctuation, although we teach, but again, I think it's not relevant to talk about fluctuation in pericardial carcinoma. If you look at serial LFT, then you could be a bit more sure about that.
Yes.
Point number one. Point number two, that the pericardial carcinoma, even if it's a 1 centimeter tumor, because the tumor at the ampulla itself will lead to obstructive jaundice because you're blocking the duct, whereas carcinoma of pancreas and carcinoma of gallbladder will take time to reach to CBD from their site of origin. Suppose there's a tumor in the fundus of gallbladder. By the time it reaches neck of gallbladder, as Dr. Mishra said, it will take a lot of time. By the time pain will appear. So is in carcinoma of pancreas. Even for head of pancreas to involve the bile duct, it has to travel to a distance of say about 2 centimeters. And therefore, the tumor will take 2 centimeters before they become symptomatic. Whereas in perium carcinoma and cholangiocarcinoma, tumor will be just 1 centimeter in size and still become symptomatic.
Just to clarify your statement, these were studies done before the advent of ultrasound. Now we are
Yes.
picking them up, and treating them very early. So the delay is not there.
Absolutely.
Earlier, a lot of delay was there.
Yeah. Jayanti asks a question. Was there any report of the MRCP that was done in their
Yes, sir,
primary
I'm going
hospital?
to show it, sir. I'm going to show
Okay,
it,
you'll show it
in the
later.
future.
Jayanti, it will come later, so we'll see it then.
Right.
Okay.
So on examination, the patient was sitting comfortably on bed. He is moderately built, moderately nourished, BMI about 20.88. His vital parameters were within normal limits.
Yeah, you tell us the relevant features. If it's normal, we'll skip
Yes,
it.
sir.
We'll
He didn't have any fever on examination. He had deep icterus, nails were shiny. He had scratch marks over the abdomen, back, and extremities. However, he didn't have any pallor, no edema, peripheral edema, no cyanosis, lymphadenopathy, clubbing. He didn't have any xanthelasma or xanthomas. There was no asterisis or other peripheral signs of chronic liver disease. JVP was normal, not raised. On systemic examination, the abdomen, the shape was flat. All quadrants of the abdomen were moving well with respiration. There was no localized or generalized distension. The umbilicus was inverted. I didn't see any scars, sinuses, dilated veins, or visible pulsations over the abdomen. On palpation, the abdomen was soft. There was no tenderness. Liver was palpable 2 centimeters below the right costal margin. The surface of the liver was smooth. It was firm in consistency, non-tender, and the edges were sharp. Gallbladder, spleen was not palpable. Gallbladder was palpable with rounded borders, soft to firm in consistency. It had a smooth surface and it was mobile side to side.
So after this, we have these poll questions. So we know what is Covershur's law, and all are the exception of Covershur's law, except that is option 1 is oriental cholangiohepatitis, option 2 is empyema of gallbladder, Mirigy syndrome, and mucociliary. Let's take the poll question.
Manav, one
Sir.
question for you. Is it Courvoisier's law or it remains hypothesis only?
Sir, it is exactly in 1890 when the Courvoisiers give their theory. They sign. They have seen that in 189 around patient, they have seen that when there is palpable gallbladder in their series.
That fortunately I know we used to call it hypothesis rather than law, you know. So I
People
wanted
are
to
saying sign, hypothesis, law, everything, sir.
Okay, okay.
So
because we were asked that in our exam.
Not
We used to
anymore.
say that is 50 years, 40 years ago.
Yes.
And we were asked and we were told hypothesis. That's why I wanted to ask you. Maybe terminology has changed.
Sir, so this is
okay.
For poll result, audience is around 50-50 oriental cholangiohepatitis and empyema of gallbladder. So this end of poll and our answer is just the time sharing it.
Empyema of gallbladder will not have
so all are exception except answer is empyema of gallbladder. So we all know what is Courvoisier's law when there is palpable gallbladder in a jaundice patient. So unlikely it is due to stone. But again, it is not always black and white like that, because when it is depend upon the time when there is stone disease, usually there is infection and gradually the gallbladder become shrinked. So we could not get the palpable gallbladder. But at times, just like Mirizi, mucosal, there is we can get palpable gallbladder in stone disease also. So, Dr. Ades, you can go ahead.
So, continuing with the examination, on percussion, the liver span was 15 centimeters. There was no free fluid in the form of shift in dullness. Auscultation, bowel sounds were present. There was no venous hum or bruit. On per rectal examination, no mass per rectum was felt. Gloves were stained with pale colored stools. There was no evidence of any rectal bleed. Other systemic examinations was essentially normal, sir. So coming to the differential diagnosis.
One minute. Basic questions, Adesh. Where do you measure the liver span? What is the normal liver span, and which study are you quoting for Indians?
So we start measuring the normal liver span from third or fourth intercostal space. Usually the dullness will start around fifth intercostal space. The normal liver span is 9 to 12 centimeters. I am quoting a paper from PGI Chandigarh, sir, 1975.
Yeah, somewhere the word mid-clavicular line has to come in that when you
along the mid-clavicular line in the vertical axis.
That is important. You are saying the PGI paper, you have to state the mid-clavicular line.
Yes, and also in the midline, if the left lobe is enlarged.
Yes.
Yes. And as we go laterally around the lower costal margin, we have to slightly move towards the anterior axillary line, sir, to find the full liver span.
Okay. And normal span in that same study which you are quoting?
9 to 12 centimeters, sir.
Okay. Fine. SP?
Yes, sir.
You are well, there's a question. If there is a mass, can you make out is a pancreatic mass or a GB mass clinically? That was a question.
Sir.
So take that and then you will start questioning you.
Sir. Pancreatic mass is usually retroperitoneal, and visibility usually reduces when the patient tries to bend forward on a recumbent position. GB mass, however, might become might be the same, and the mobility of normal gallbladder is from side to side, and it moves with respiration along with the liver.
So GB mass will be in the GB fossa, like
the site will be different.
In the midline or somewhere there. So you can differentiate between the two, but sometimes if it is all matted and things are topsy-turvy, then it will be very difficult. But that should not be a problem. But this is a globular mass, you said.
Sir.
Yeah.
So just to add to that, most of the patient with carcinoma of pancreas will not have lump palpable. Only less than 10%
Yes.
is lump palpable, because lump from retroperitoneal to become palpable, the tumor has to be too large. And before that, so they are more of cystic tumor of pancreas rather than adenocarcinoma of pancreas. And that too, body and tail of the mass in the body and tail of pancreas could be larger in size before they become symptomatic in terms of jaundice. So the pancreatic mass will be distinctly unusual. Number two, the gallbladder is, as you said, Dr. Mishra said that the GB fossa. It could be soft cystic gallbladder. It could be a hard or firm gallbladder. The firm gallbladder will mean that it may be mitosis that way.
Is this your order, Adesh, that you are, or would you like to modify in the light of our earlier discussions?
Cholangio, I will keep it first, sir.
Okay.
I would still at this point, because the gallbladder was palpable, I would put ampullary as second.
Okay.
So now you can say cholangio where?
You have put distal and perihilar.
Distal will be first, but if the perihilar is involving the cystic duct or anything, then that also comes into the differential diagnosis, sir. Distal will be the first differential.
Can it be carcinoma of gallbladder?
Here I found the mobility was preserved and the consistency was soft to firm.
Okay,
It
suppose
could still be neck of the GB might be involved.
Yes, neck, like a mucosal.
You get a
but the commonest part is the fundus.
If it is at the neck, you get a mucosal and you get a CBD obstruction, CHD obstruction.
Yes, but the commonest part of the GB to be involved is the fundus, which is seen in 60%. So I've kept it last.
Third.
Again, your index case is an index case, one case. That may be a case report for you then.
Sir. Yes, sir.
And all other colleagues, the one other point is to say that we see patient at one point of time.
Yes.
So the disease is a spectrum, the full spectrum, right?
Sir.
So to say that it's not carcinoma of gallbladder because the mobility is preserved, are we predicting or are we presuming that all tumor are there no tumor to an advanced tumor? So the tumor will increase in size with time, and therefore the mobility will also decrease with time. So at a given point of time when patient comes to you, you will not have all the classical features. So we need to keep that in back of mind and always think of a whole spectrum of a disease. If from normal gallbladder to a small lesion, to a lesion progress over time, and then becoming ultimately a full-blown disease with the involvement of multiple organs. So there's always a long gap between these two. So we need to keep that in mind. And it's not right that we want to be right always, but we should be like to be logical always, right? Diagnosis may be anything, but again, as Dr. Mishra said, it may be you have to. I mean, you can't rule out a carcinoma gallbladder as such.
Again, what Govind said, if you're logical, majority of time you'll be right.
Okay, so we are somewhere in those three now we are putting. Should we go ahead to the investigations or what, SP? We've got 45 minutes, and so
I think
there is a question from Ajit. Will you take it up?
ask him the question.
Yeah, the question is,
yes,
in oriental cholangiohepatitis or an infected mucosal, why the gallbladder is palpable?
Oriental cholangitis, the infestation will be in the CBD, sir.
Yes.
So it will act like a primary CBD obstruction, like a CBD stone obstruction.
An empyema, it will be in the neck. Okay, go ahead.
Right.
So,
Manas, question
yes,
3.
sir. For next poll question we have, the percentage of patient presenting with painless jaundice in carcinoma head of pancreas or carcinoma gallbladder. Already we have discussed this, but let's take the poll question. Option 1 is 60
The cat
to
is out of the bag.
50 to 60%, 30 to 40%, and 10 to 20%. Because can we help our poll? Sir, yes, sir, it's there.
Even
So,
after even after the cat is out of the bag, some people are.
Sir.
Yes.
So majority are right, sir. Around 75% of the audience are right. So answer is 30 to 40% again.
You show your next slide for the answer, then they will.
Yes, sir. This time.
We just Manu bhai, we just discussed it. We're asking this
I
question.
know. Just told it and including, but I don't know how many joined late.
So
Go to next slide, Satya.
he is. Yes, this is the again series from SGBJ group. They have percentage of patient having painless jaundice in case of CHOP, and GB is 30 to 40% around. This is published in Advanced Research of Gastroenterology and Hepatology 2017. So, Dr. Adis, can you go to investigation?
We'll move on to the investigations. So on evaluation, he had mild anemia, microcytic, hemoglobin was 11.9. There was no leukocytosis. Platelets were he had mild thrombocytopenia. On LFT, he showed a gradual progressive obstructive pattern of jaundice with bilirubin rising from 4.5 to 19, and mild transaminitis and significant serum alkaline phosphatase elevation. This last report is showing a dip, just that is in view of upper limit of that is change in the upper limit of normal levels in respective labs. The last value is of AIG. It is upper limit is 120. The other labs upper limit is 300. So there is a progressive obstructive jaundice. Albumin is gradually reducing. Initially, his INR was deranged. It was 2.75, which was corrected with vitamin K, 1.22, which turned to 1.22. Renal function tests were within normal limits. Viral markers, hepatitis, especially hepatitis B and C, were negative.
Satya, when was the ultrasound done? Date? You have a date? See, I'm worried about one thing. We have already spent 23 days. If a diagnosis was made, getting all this doesn't mean.
Right.
Doesn't make
so
sense.
between 3rd and 14th, he was in this thing, sir. He was in Assam.
I'm not
That
worried
was the
about
first time, sir. That time he had undergone an ultrasound, sir. When the second report had come of jaundice, he had undergone the ultrasound, which I'm going to tell you next, sir.
Okay.
Sir. So ultrasound showed.
What I was harping on is we have lost 23 days in between.
Sir.
That's very important for the patient.
Sir. So ultrasound abdomen showed an enlarged liver. However, the span of the liver was not mentioned with dilated intrahepatic biliary radicals. CST was poorly outlined. It was documented that they suspected a likely stricture. Gallbladder was distended with normal wall thickness. There was no stones in the gallbladder. CA19-9 was significantly elevated, more than 1000. IgG4 we have sent from here, sir. The report is still awaited. So this is the MRI after the USG abdomen. He had got it done in Assam with MRCP.
This, I mean, just for benefit of everyone.
Sir.
So what we line of tests say that so this is also important consideration that many places the MRI will not be available. So rather than going what test was done, what test you like to do, and we'll show those tests. Manas only show those tests which was required for this diagnosis of this patient.
Yes.
Because
so
why would you do IgG4? So let's not leave a wrong impression to all the residents that IgG4 to be done unless you're thinking of IgG4 related disorders. Then you think of IgG4. Certainly, IgG4 will come lower down in the.
Yes, sir. It should have come after the MRCP, but
certainly it's come down lower in the. So that we go by as patient develop. We go by that algorithm,
sir,
rather than what test done here and there.
Right, sir. So first, I would like to, as it is showing a obstructive jaundice, I would go for ultrasound abdomen with a color Doppler of the abdomen. which in where we can see if there any biliary dilatation is there, intrahepatic or extrahepatic. See the gallbladder whether for any stones or masses. Look for lymph nodes if any. Look for ascites for early staging of the disease. And even head of pancreas is seen in some of the cases where there is a mass in the head of pancreas with distal CBD obstruction, or if there are any bile duct stones or anything which are obstructing the periampullary region. So if there is an extrahepatic biliary obstruction, I would like to without a GB mass. GB is ultrasound is very sensitive for gallbladder tumors, so we can make an initial diagnosis of CAGB on ultrasound itself. If gallbladder is normal and there is a extrahepatic biliary dilatation, intra and extra both, I would like to go for an MRI with MRCP. Sir. So in this case, MRI plus MRCP showed liver was normal in size with and signal intensity. Bilateral intrahepatic biliary radicals were along with right anterior and posterior, and sectoral hepatic ducts, and also the left hepatic ducts were dilated. There was an ill-defined T1 hypointense, T2 hyperintense lesion, which had shown diffusion restriction and also a delayed enhancement on post-contrast scan in the hilar region, which was involving the confluence, right and left hepatic ducts, and also a proximal CHT. The region was also likely infiltrating the left portal vein because it was not visualized. Few subcentimetric enhancing lymph nodes were there in the periportal region. Gallbladder in this scan showed normal, was normally distended. The wall thickness was also normal. There was multiple T2, there was evidence of hepaticolithiasis in the left intrahepatic biliary radicals. The CHT and CBD, however, they had given a normal dimension with CBD showing some sludge. So they gave their final impression as hilar cholangiocarcinoma, bismuth type 4 in view of segmental ductal this thing, and involvement of left portal vein and some subcentimetric lymph nodes. So in this MRCP, you can see the hilar lesion on the film where the arrow is pointed. You can see the segment 2 and segment 4 and segment 3 duct separated on the left side, and also on the right side you can see the separation of CHD followed by interruption in the biliary anatomy, followed by segment 8 duct and segment 7 duct, right posterior duct on the right side.
You have this picture over there, the involvement of the portal vein.
Portal vein, actually, I have a CT which is showing that, sir. So I had not put it in this, sir.
Okay,
We were not able to clearly see it in the MRI film.
If you have got a CT done or a CT angio done, involvement is there. Now, would you like to have an IG4 in this case?
The IgG4, why we had gone is we had he's a young male who has come with a suspicious mass.
Short history, male, weight loss, asthenia, and with this picture.
Yes, sir. If with the preliminary evaluation, if the structure or the mass is we don't come to a final diagnosis, then IgG4 has to be suspected, as it can masquerade as a tumor in the hilar region.
Will it involve the portal vein? The spread will be there. That is the problem.
Yes, sir. That is more portal vein involvement is more likely to be malignant.
Can it be in benign disease? More likely means it can be in benign disease.
Inflammatory changes, they can have portal vein thrombosis.
No, involvement is infiltration is not inflammatory change.
Infiltration is not usually seen in inflammatory diseases.
It's infiltration basically. You
Yes,
see
sir.
such a
Adesh,
Sir.
there was a question, SP, sorry, the one question, this of course came from there, but they wanted to, there was a question, given a choice, will you do a CT first or an MR first? That was the
Given
question.
a choice,
Yes,
if for a
Benjamin.
hilar carcinoma, I would do MRCP with MRI because we can know the biliary anatomy and also the vascular invasion. But CT is best for vascular invasion and also to plan for preoperative resection.
Resectability is better seen on.
Resection. If you are
Yes.
planning, then CT would be better.
Yes.
Okay, so sometimes you need to do both, one for
Yes, sir.
anatomy, one for resectability.
Yes, sir.
Okay, that answers that question. Okay, sorry, SP, go ahead. I just took a
My question
from.
got lost.
Ah,
Never mind.
doesn't matter. Nowadays,
Go ahead, please.
6,000 we can afford. Chalo.
So, now, before that,
Sir.
And one more thing, sir. Is there a role of CA 99?
1,400.
Is there a role
1800,
of
sir,
that?
1800.
Is there a role for that?
So post-operative resection after
No,
the
no,
resection.
this was done pre-operative.
Yes, sir. Yes, sir.
So role,
So
I'm talking
more
about
than
this.
more than 1,000, it is the more towards malignancy. But in case of cholangitis, also we can find CA99 more than 1,000. But in the background of mass with the CA99 elevated.
That's why I'm asking about this patient. Weight loss, short history,
Supportive evidence it
you have
gives
MR now. You have
So it
ultrasound
gives-
now.
Yes, sir.
It is
And
supportive
it also
for malignancy.
and
Supportive,
it also
not
suggests
inclusive.
metastatic disease, which mostly is unresectable, sir.
A couple of points I want to make out here. The first thing that after your clinical diagnosis and your basic investigation, there's an obstruction to bile duct, and bile duct obstruction is at the hilar of this thing.
Yes,
so this MR tells you that there's a multiple ductal involvement. So this is number one. So it means the tumor looks to be more aggressive.
Yes, sir.
Number one. Number two, that it only involved portal vein. The more important point I want to make that there is a hepatolithiasis. It means what? It means two things. One, that the bile is supersaturated, and therefore it forming hepatolithiasis, or is there a disease which predisposed him to develop a kind of cholangiocarcinoma?
In fact, it's a precancerous condition, Govind. I agree with you. I was going to ask the same question. Oriental, and then it's a pre-malignant condition for cholangio.
Because in most of the cholangiocarcinoma, short duration disease, you don't expect the liver to have multiple stones in the bile duct. If there are multiple stones in the bile duct, it simply means that the duration of disease is probably a bit longer than what it appears to be.
Yes, sir.
And because he's symptomatic for last 6 weeks only, so that's a jaundice. But disease may be there for a longer period of time. And there's the role of other benign etiology, as Dr. Manu says, other benign etiology, which degenerated into malignancy with time, especially in a young person. Therefore, you realize that why Dr. Mishra and why Dr. Tandon and also Dr. Saraswat have been raising a point. Why won't you consider a benign disease in differentials? Because age was a bit younger. We don't want to say that a tumor don't occur in younger age, but it's good to keep a wider perspective.
I think, Adesh, this is a case where, as Govinda said, where not only the diagnosis is there, you got a pre-cancerous condition also pointing out in this imaging.
Adesh, but
we didn't have a history, so we didn't know what happened earlier.
You could have been more certain if there were hepatolithiasis.
And 6 weeks is too less to get a stasis and obstruction.
Yeah. So we probed him for any evidence of cholangitis in the past or any history of fever. He denied.
Oriental is well known to RPC is well known to be silent.
Yeah, what we are harping is you have an open mind and think about it.
Yes.
It may not be there. Most likely it's not there. Second thing is from Northeast. North is very close to the Orient.
Oriental, this thing is very common.
One other point.
Quite a few things which hold on towards cancer and precancerous condition. Nothing will prove it now, but yes, worth considering.
Presence of hepatolithiasis, some left lobe atrophy is also there.
Yes, and short duration, 6 weeks, you don't expect it in a young man.
Yes, sir.
Does he have also CBD stone?
But one thing, again, if it is 6
small
weeks.
CBD stone is also there, sir.
Yes.
Yes, the ones you can see a CBD stone. But in 6 weeks or 4 weeks, would you have atrophy of the left lobes so fast?
It must be there from before. It must be there from before.
So what
Yeah,
Govind
it
was
must have
saying,
been pre-existing. One question from Ajit you have to take. We are taking questions. Can you point out the stones in the MRCP or any imaging?
yeah.
Yeah.
In the
can see
lower
Manas,
segment of CBD, one stone
Yes,
is there,
yes.
and then in the left
that
appendix,
is
some
one.
hypo.
He wants in the left ductal system.
Yes, sir. In the hypo, there are some hypoechoic structures. Yes, that one.
Yes. Yeah.
Yes, sir.
In
I
one of
think
the
that is a
segmental drugs you can
segment
see.
2 duct, sir.
There is another question because of the portal vein thrombosis.
Yes, that can
Probably
explain
that lobe got atrophied.
both
6 weeks.
inadequate drainage and portal vein obstruction. Yes, sir.
Yes, but I think the alone portal vein again 6 weeks is a very short time. I think it's
short time, very
pre-existing
short time.
disease.
Yes, sir.
Would you also consider with multiple ductal involvement is the PSC as one of the differentials?
Dominant
He is in the
stricture.
hilum, and there is a mass, sir. So PSC.
No, PSC with cholangiocarcinoma, not only
Well, PSC is also a precancerous condition, mind you.
Yes. 10% chances are there in PSC.
I thought pruritus would have come much earlier than 6 weeks.
Yeah,
Govind.
and
What do you
recurrent,
say?
intermittent recurrent cholangitis.
Dominant, Govind, pruritus may have come much earlier if there was a dominant stricture pre-existing.
And these are the guys who get xanthomas and xanthelism because the long-standing cholestasis is there.
Yes, and not in a short time, and we don't see very often.
What I mean to say that once we talk of RPC or then we also talk of PSC, and PSC may have a multiple site disease, involvement of bile ducts at multiple sites. And the point I want to make that we shouldn't look PSC at the time of when there is a bleeding. Although I don't say this picture is like PSC, this MRCP picture, but we shouldn't expect that we should diagnose PSC only once there is a bleeding appearance. Bleeding appearance is the end stage disease, which is so classical. It's very specific for PSC, but that's the end stage disease. So we need to pick up a disease early in the course. Even multiple sites of thickening of gallbladder, thickening of bile ducts, and multiple site stone itself should be sufficient to think of PSC in our differential diagnosis. Right.
Okay, let's Adesh,
Move on.
Can you go ahead now?
Right, sir.
So what do you know? What do you want to do now? So what's your question now? So with this now a mass lesion, what's your question? And then we proceed the investigation. What is the question?
So the mass lesion looks unresectable. So we have to in view of progressive jaundice in a malignant lesion, we have to first look for biliary drainage first. I would prefer doing a percutaneous biliary drainage in this case, as the lesion is higher up. If it would have been a type 1 or type 2, I would have gone via with no left lobe atrophy. I would have gone via ERCP. But I would like to do a percutaneous biliary drainage because there are we can selectively cannulate the duct and we can avoid the retrograde transmission of the dye, which can cause cholangitis, which the patient is at high risk after
Can you
ERCP.
mention the studies which have come from India where they have shown that for type 4 PTBD is superior to anything?
Yes,
you know, for the exam going, that's commonly asked, since this is a type 4 stricture, all the ducts are separated.
I'm not able to recollect, sir, but ESG guideline, they recommend.
ESG says, I asked specifically from India.
I cannot recollect, sir.
Both
Adesh, you said one thing.
have given that.
You said that had the left lobe was not atrophied, you had done an ERCP. ERCP or EUS?
EUS also was there.
EUS also was this thing. If the left lobe was not atrophied.
ERCP will not help you. Had the left lobe not been atrophied, an endoscopic ultrasound guided rendezvous or a retrograde placement of stent would have been possible.
Yes, sir.
This again, one more point, since the image is here. See, bilirubin is now 14, 15. Is it so?
19, sir.
19.
Sir.
And look at the bile ducts. The central bile ducts are distended.
Yes, sir.
This distance is not going towards periphery.
Yes, sir.
below 19, we expect that if there's a obstruction at the center, like the hilum, then we expect that all the ducts distal to that should be distended. But here, most of the dilatation is occurring in the central region
Central
of
IHBD.
all the segments. But as you go to periphery, they don't distend.
Mildly distended in the right side, left side or more
in the right, the one above the other. And that will be interesting to know that is it a pre-existing liver disease not allowing the ducts to distend? And this may be again one of the other pointer to tell you that this disease may be a longer than what it appears to be. Even the left system, you find that only central are dilated, and as go along the periphery of the liver.
I have another explanation for that. Govind, I feel that the 6 weeks duration has only allowed it to come up to the central. Give it another 6 weeks, everything will dilate.
Yes, sir.
I feel so. I don't know, I may be wrong.
6 weeks is too long time for them to dilate.
No, peripheral also.
I think so. I think 6 weeks is too long. And it's the more proximal, the more dilation will be there.
Yes, that is there always. But Govind is asking about distal dilatation vis-a-vis a chronic liver disease, pre-existing.
Not chronic liver disease, but some kind of
pre-existing liver disease.
Prime, I mean, some kind of bile ductal disease.
Yeah,
disease.
like sclerosis.
It's not a liver disease. The liver looks normal.
Chalo, let's move then.
So we did in US. In the US, the gallbladder was distended and anechoic. CBD was measuring 7 mm. It had a stone at the lower end of CBD. Left hepatic duct was grossly dilated with intrahepatic ductal calculi. Right hepatic duct was mildly dilated. Hilum in our US could not be visualized well, so we couldn't see the mass well. Pancreas and pancreatic duct were normal. A few enlarged lymph nodes were there, but then again they were benign appearing. And we took an EUS FNA from the hilar lymph nodes, but the tissue turned out to be a benign lymphoid tissue. So this in the left picture, you can see the lymph node which is marked. There is no necrosis. Lobulated lymph node is there, and in towards the right, you can see the left hepatic duct with the intrahepatic calculi. You can see the post-acoustic shadowing of the calculi there.
I think Ajit, this is showing it much clearer as compared to the Ajit had asked that question.
Yeah,
this is showing it much clearer than the MRCP, though in MRCP it was clear. But
in MRCP we had a atrophy of the ducts were not good. Well seen in the
this
left
is showing with the acoustic shadowing you can make out.
Yes, sir.
Fine. I think Mana's question is for then we'll discuss.
So if it is a hilar cholangiocarcinoma, if you are suspecting, which of the following is not a criteria for unresectability for hilar cholangiocarcinoma? So for this poll question, we have answered atrophy of the unilateral liver lobe with encasement of the ipsilateral portal vein branch. Second is bilateral portal vein branch encasement, bilateral hepatic artery encasement, or type 4 bismuth. These are the options. Let's see what is our audience thinking. So we'll have a poll. Till now, majority of are thinking that is atrophy of the unilateral liver lobe with encasement of the ipsilateral.
Yeah, but I have a question. Out of 157, only 100 people are answering. But why is that?
Nota. They're using Nota.
Nota, okay.
Also, a lot of faculty member here.
Memorial Sloan Kettering criteria, very well documented. Unilateral and ipsilateral and contralateral, both they say. So this is classical from that criteria. And I think, Manas, everyone is right.
Sir. So let's go ahead.
Sloan Kettering gave this 3 criteria. Okay.
Yes, this is answer is atrophy of unilateral liver lobe with encasement of the ipsilateral portal vein branch. Next, Dr. Rajesh.
As we got a negative from FNA, and we didn't still have a tissue diagnosis, we did a whole body PET CT,
But
which
if
showed
it
the
was done, was if any done?
Yes.
from the lymph nodes, sir, lymph nodes.
Okay.
Not from the mass. It was taken from the lymph node only.
Lymph nodes. So FDG avid ill-defined soft tissue mass, which was measuring 2.3 into 3 centimeters, which was involving the common hepatic duct, primary biliary confluence, right hepatic duct, left hepatic duct, which was causing bilateral upstream IHBRD. The lesion was encasing the left hepatic artery also. It was closely abutting the right hepatic artery, and it had lost fat planes with the left portal vein. Some FDG avid lymph nodes were seen in the periportal region. There was no ascites. This is
For
the
cholangio, a question, Adesh, for cholangio, what would be the SUV cutoff that you would consider to Bird's malignancy?
more than 10, sir.
Now here you've got only 5.6.
5.6. Yeah.
So
A lot of desmoplastic reaction would be there. So that might be the reason for the low SUV, sir.
yeah,
But
but
it is lighting up.
it is lighting up, but statistics or literature says that you must have roughly 10, no?
Yes, sir.
So-
This is a PET CT where on the left upper film we can see the lesion. Yeah, that is the lesion, and which is closely abutting the right portal vein. You can see some segmental ducts there, segment 8 and segment 7. On the right picture, you can see the left lobe, which is atrophied with significant intrahepatic biliary radical dilatation. And in the lower picture, we can see the FDG avid. Sorry for the quality of the picture. Some FDG avid lesion in the hilum.
From what I'm seeing, others they're not very bright yellow, you know, they are just some faint yellow coloration.
Yes,
Yes,
even I was.
So SUV max is 5.6, sir.
Right. I'll just take a break. Jayanti, I'll answer Jayanti's question. Jayanti has put a question. What about spy scope and get a tissue? Jayanti, the plus point of spy scope is it is a hilar lesion, you can do it. The negative with type 4, if you push a lot of air or water or contrast into one of the undrained segments, we are going to, the patient is going to go. The cholangitis incidence is theoretically 3 to 7. In this, it will be 20 times higher because we will not drain all the segments. So there's a negative point. Biopsy will be targeted, but visual impression is as important. The only negative point is, I'm sure in this patient with all the ducts separated, we will induce cholangitis.
No, but do you need a tissue diagnosis right now? With so much of involvement of the ducts.
She wrote for that only. She wrote that
you don't need
a tissue through a spy scope. So I said, this is the plus and minus. You will have to be ready with a PTBD or whatever EUS, not in this case, but something to drain after cholangitis, because I feel the incidence will go more than 20%.
No, you're risking the patient then.
Yeah. Okay, sorry, that was a question which Jayanti asked. Now let's see this.
So if we have done a PET CT here, let's ask poll question 5 is sensitivity of PET CT for detection of local lymph node metastasis in perihilar cholangiocarcinoma. So option 1 is this is 53 to 65%, 13 to 38%, 70 to 84%, or 5 to 10%. Let's see our poll. So majority are going for that is option 1, but PET is not a good modality to see the localized lymph node. That is for the information only.
Yes, and let me also tell the students, even for HCC, PET is not a sensitive pickup rate. So, you know, just blindly, if we write HCC PET and not get an answer, doesn't rule out HCC. Both for cholangio and secondaries, just little. So maybe that low yellow color is part because, as Adesh said, there is a desmoplastic, very few cells which will take up.
Yeah,
So-
even an inflammatory reaction over there will give you 5.6.
Yes, we'll give 4 or 5. So you have to take the whole clinical picture. This is especially regarding to liver malignancies and
Ajit, air
cholangiomas.
cholangiogram is as bad as cholangiogram. Pressure will
Randhir
increase.
Sood, Ajit, Randhir Sood had published that first study and he has subsequently done. I'm not sure if you put in a brush,
problem.
anyway, there will be some
Pressure,
infection.
the pressure will do the trick.
Yeah, push here. And with type 4, there will be definitely some segment which won't come out. So it's a questionable. It is better than contrast, but not absolutely foolproof.
Okay, let's go ahead.
Can we move on? Yeah.
You have the answer now.
So
Can you
it is
remove-
around 13
remove-
to
Okay.
38.
Yeah. So not very sensitive.
Oh,
We'll
I
come
mean-
to the treatment later, I think, no?
Yes.
SP, we'll ask some questions on this.
Okay, go ahead.
Can I ask one question now? So what the next
Yes.
step you want to do? So we have we know the lesion, but we know type of lesion. So Ades and Satya, what will be your next step? Certainly we're going to drain system later, but what will be your next step to resolve the diagnosis and diagnostic possibilities?
As said, spike cholangioscopy would be the next this thing to obtain a tissue diagnosis. But again, cholangitis,
The risk of ascending cholangitis.
ascending cholangitis should be considered because this is a type 4 inoperable tumor. We have to get a tissue diagnosis for giving him definitive chemotherapy.
So
Palliative therapy.
are we sure this is a tumor? Could this be a benign lesion? Because on PET scan, there is no high uptake. So
Sir.
it could be more of desmoplastic, as all you have been discussing. That could be a non-tumorous desmoplastic tumorous lesion or maybe inflammatory lesion.
Inflammatory IgG4 we can consider, but again, it would be difficult to diagnose without the tissue staining of IgG4.
So would you do a tissue biopsy doing a US guided, maybe ultrasound was negative? So more attempts either at lymph nodes, because one
Yes,
test, one attempt giving negative report doesn't
Yes.
rule out
Yes.
either inflammatory or mitotic lesion.
Yes.
So repeated attempts probably, what Dr. Tandon says, that more attempts at the diagnosis.
There are two pointers. One is the hepatic artery is also involved, vein is involved. So there's a lot of involvement there. The patient is inoperable. That has to be a malignant process.
Absolutely, I agree on that. Just to probe on that, would you like to?
So you do an endoscopic ultrasound again and take a biopsy again.
And Jayanti has put a question. I want both of you to answer. Extrahepatic biliary obstruction, imaging, and PET versus EUS. Where do they relatively stand? EHBO. I think you can start with proximal and distal. You will probably pick up where you can answer that better.
Distal,
Distal cholangio, we can, ES is more sensitive, sir.
Correct.
Proximal.
And you got the advantage of a tissue which is now
yes,
important in case it's inoperable and you need to give chemo.
yes.
And otherwise, Jayanti, cholangio little poor uptake is there. So that you must keep in mind when we see for proximal lesions.
And Manu bhai, how much, even it can be a sclerotic lesion and you will not get tissue diagnosis.
Yes, correct. You will not. There are many limitations of both the things, but
Yes.
I think the overall picture with help of this, the only
And again,
point
spy
I
will,
insist,
spy
what
will
you
not.
both are saying, repeat US is because in this patient index case, he'll need chemo as the only salvation therapy. And for that, at least invariably, you need a tissue for the oncologist to move ahead, you know.
Absolutely.
So-
And I think that's an important lesson to learn from this case, that we'll put in more attempts to do FNA and take a tissue to make a diagnosis, and so that you can give no, I mean, where this tumor is unresectable, so local chemotherapy.
Again with US you can target lymph node. With spy you do only intraductal.
Yes. And also maybe that the tumor itself, not only lymph node, but also the tumor
Yes,
during UM.
both can be targeted.
Yes.
Okay, theoretical questions for both of you. Now, this is a intrahepatic cholangiocarcinoma. Let us assume we get a tissue. Relative status, are we doing any brachytherapy there? What is the role of radiofrequency ablation? Maybe in general, specific, in this case you can mention. And what about phototherapy? All three, they're all palliation therapy for intrahepatic lesions. Where do you place them in general and in this case?
So you are trying to place iridium?
Yes, iridium through an NBT 192. So have you heard any work done on all the three? Phototherapy,
Photodynamic therapy.
radio frequency ablation, you would have seen at our center a lot.
Yes, sir.
And third one, of course, is iridium.
None of these have a large trials. We can call them as experimental therapies. Retrospective studies have shown progression-free survival in combination with RFA plus SEMS in biliary drainage, and same goes to photodynamic therapy and brachytherapy. As of now, where we stand, we cannot recommend them as the standard of care for palliative treatment.
In this patient, will any of the three apply in this? I was assuming we have phototherapy and the patient can afford the cost. We are not talking about limitations of cost. In this patient, let's talk index case. Which of the three, or none of the three, or all the three?
RFA can be tried in this, sir. Brachytherapy, I'm not sure, sir.
RFA, where will you do the RFA? You
have to have an access.
Yes, I don't think you can do with this with all dissociation. I don't think any of the palliation methods, the best you can do is a PT-PD or a US if you can attempt on the other side and push in stents. I don't think there's anything in this patient we can do. The only thing lacking is a tissue diagnosis still.
Yes, sir.
There are a couple of questions, and I think they're relevant on the imaging of such patients. The question from Dr. Khandelwal, Sachi, and Dr. Jayanti, all making the same point that once we locate the lesion, the tissue diagnosis remains the center, and we do image of either CT, MRI, contrast MRI plus MRCP, or EUS, or the PET scan. So they will have they will tell you more about the extent of lesion, but all patients may not require all these tests. Every patient, certainly this has to be individualized, but more important, the tissue diagnosis remains at the center. And by any means, you say resectable tumor or unresectable tumor, so define. Every patient will not require all the tests, but certainly in difficult patients like this, you might have to resort to many investigations.
In many patients, no matter what you do, you will not get a tissue diagnosis.
Absolutely. So the message must not go with all the residents and all the participants that every patient has to undergo a CT scan, MRI, US, and a PET scan. But it's only an individual clinical decision. Only one test may be simple CTC. For this patient, a CT should have been, or MRI should have been sufficient to let us know that this is an unresectable disease. Right. So next.
Okay, now let's see what was done at the hospital. Show us.
So in view of worsening bilirubin, he underwent percutaneous transbiliary drainage. They cannulated the segment 6 duct and 8 ducts. You can see it in the left upper film, which is showing the cholangiogram. The opacified duct is the 6th duct, and you can see a part of CBD with a small stone below also. There is a part which is not opacified in the between. In the next film, you can see the segment 8 duct, which is a cholangiogram of the segment 8 duct. 6, they have already put in a PT-PT catheter. In the below films, you can see both catheters, one in the segment 8 and segment 6. and in the final film, both have been internalized.
So they were
PTBD
able to pass the mass.
Yes, yes.
They were able to go across the mass.
Yes, they crossed the mass structure and they had internalized it.
Yeah.
But the issue was post PTBD. After one day, he started developing fever. So
that
next
shows-
we have done.
Oh, go ahead.
We have done an ERCP. Rendezvous technique was used. Papilla was normal. Both PTBD catheters were visible. Both the PTBD catheters were cannulated through the PTBD catheters. The ducts were cannulated with the PTBD with the help of PTBD catheters. CEBD showed mildly dilated. It had a stone at the distal end, and there was a long stricture in the hilar region. The cholangiogram again showed right anterior and right posterior ducts were not communicating. Left was not at all opacified. We did a biliary sphincterotomy. We saw pus draining from the ampulla. Stone was extracted. We took a brush cytology and a biliary biopsy from the hilar stricture. 7 centimeter 7 French into 10 centimeter double pictal biliary stent was placed into right anterior hepatic duct, and an NBT was placed into the right posterior hepatic duct. In these films, you can see this is the sixth segment 6 duct with the PTBD catheter in. This is the long stricture in the right image, which you can see, which is continuing from the mid CBD to the proximal
Manas, can you point it?
CSD in the second film. And in the last film, you can see the one stent and one NBT, which is placed into the right anterior and right posterior hepatic ducts.
Adesh, you put in dye and the left duct was not opacified.
Not opacified, sir.
If something had gone inside the left duct, there would have been problem.
But
Then
still,
external drainage.
There's no scope of drainage.
Yes, sir.
Atrophied. Everything is atrophied. I know. That's why that Jayanti's question I'll answer. Jayanti has asked ERCP, PTBD. Type 3 Jayanti is depending on the expertise you have. Type 4, you only PTBD preferred over ERCP. Endosono guided is coming rapidly if the liver is otherwise normal and not shrunken. So type 3, you can have an option depending on our expertise. Type 4, non-ERCP drainage, I'll say. Most of the centers do PTBD, but if you have got again the expertise, you can try an EUS guided also.
You can only do in the left duct on that side.
Left side. That's what.
Dilated third
provided the liver anatomy is favorable. That's what I said. Provided the liver anatomy is favorable.
Segment 2 or segment 3 can be drained.
Yeah. And you can put a drain from there also. If the stricture is very tight, hepatico-gastrostomy, and they put in a stent also.
Yes, and then you can put in a guide wire and then you can do a non-do and then put to the right duct also.
Yes.
So, no, that was a question. I took it up.
Go ahead.
So, any other comments on the case?
You're finishing right on time. Very good.
Govind?
Yes, I think
we are 2 minutes short. Anything from you? I'd like to ask them a little about benign,
what happened to the
cholangitis also.
What happened to cholangitis?
For teaching purposes. Is that okay?
yes, sir.
Okay, now benign. We have talked about malignant. I want you have listed out the benign. What are the types of benign lesions you get following OLT? Benign strictures we have come. Theoretical. I'm not talking of this index case.
Anastomotic side
for exam.
we can have, sir.
That's the
It
common.
It can be ischemic also.
Yes.
I'm not hearing clearly.
Manas, can you stop sharing the screen?
Yes, sir.
He said anastomotic and ischemic.
Yes, sir.
Good. Okay. What is the difference between anastomotic and ischemic and their response to endotherapy?
Ischemic, if it is early within the first week of the post-LT, it is not visible for the endoscopy, sir. Anastomotic site stricture.
Anastomotic strictures are localized. They are at a single point and they are amenable to endotherapy, single, multiple plastic stents. In rare cases, they're fully covered, but multiple will be enough. Anastomotic strictures could be both intrahepatic, extrahepatic. They are long, they are irregular. They come under the classification of complex strictures. 25 to 40% respond to endotherapy. Sometimes they are an indication for a retransplant also.
Ischemic you're talking about.
Ischemic, sorry, anesthetic, sorry. The second one was a complex ischemic. The first one is the simple.
And if you have a higher HAT, then chances are there.
Then gone. Hepatic artery thrombosis, even worse. You may
Just
need
to so just to close the case, the first that as Dr. Satya and Dr. Ades has told, the two reports are still awaited. The biopsy have been done, so biopsy report will come, and then based upon that, I suppose more treatment will be planned. And second, that IgG4 level is still pending. So at this point in time, the treatment have been done was palliated, but again, more definitive therapy, whatever possible therapy is to be done, will be based upon the FNA report which is awaited, and also the IgG4 levels which is still awaited. Am I right, Dr. Tanan?
Yes.
Adesh, one just question. Can you get samples from the PTBD? If you do a PTBD and they can, somebody has done brushing from there?
Get brushings from the PTBD samples also. And cholangioscopy guided from the PTBD site also we can.
And that can also be done.
Yes,
Once you have a thicker catheter.
You have to upgrade the size of the PTBD tube, and then once it matures, you can push in the short scope. That is the short spy scope, where the classical one is different.
I think we can the time to close this 1 o'clock.
Thank you. Wonderful.
So, no. A couple of points just to give a summary. Do you want to give summary, Dr. Tandon or Dr. Mishra? Learning points in this case.
No, bhai, it's your case.
Okay. It's from the learning points for students. First is from the history, do your best to differentiate intra and extra. And if you are not able to, as we ask in the exam, a syndromic diagnosis, you say that based on this matter, I cannot really differentiate whether it is intrahepatic cholestasis or extrahepatic cholestasis. That is very important. Don't commit.
And always have a differential diagnosis.
Yes. So that is the first learning point. Then the second learning point is there are 5 of benign and malignant. By statistics, 72 to 75% are malignant. The rest are benign. You must know there are 5 malignant causes, 4 they listed, the 5th one I pointed out. We have discussed in detail where pain is available, which is painless, and statistically, which is the commonest in your area. If there is a precancerous condition that is existing in this patient, I feel there was, then all the more that lesion will come up higher, like a cholangio. If there was a PSC, then it comes higher up. That is on the malignant side. On the benign side, many other things, but post-operative, chronic pancreatitis, and then the miscellaneous, and don't forget tuberculosis in our country. Innumerable times we have, malignant, and then frank caseating pus from the lymph node drops out, So don't keep that in mind. 4th learning point, which is the imaging technique that you should appropriately set, and that was raised, that in certain 1 or 2 may be more than enough. You need not have to go to multiple imaging techniques to establish both the diagnosis and the resectability criteria if it is malignant. 5th, if it is gone beyond 3 or 4, depending on the expertise of your center, this is now malignant. Which one would you like to use for a drainage procedure to alleviate the symptoms? Mostly jaundice, pruritus will be higher, sometimes cholangitis. So PTBD versus ERCP, if you have US expertise, that also comes into the picture. So these are the important things that you should carry when you leave the hall that you will leave very shortly.
Unless you have any point to make.
All points mentioned by Manu sir, we have to keep all those things in mind, open our mind. Suddenly don't jump into extrahepatic biliary obstructive jaundice, because at times it is very difficult to differentiate intrahepatic cholestasis also. So those are the points.
And in
examination, learning from me, from the expert also.
in the examination, never know the diagnosis. Once you know the diagnosis, you only hover around that. So then you can't think outside the box.
Correct. Biased.
Unbiased.
Your answers become biased.
I think
Okay,
with this, with this we close today's session. Thank you everyone for joining in. Thank you, Dr. Saraswat. He has to leave early because of his flight. Then Dr. Misra and Dr. Tandon is a wonderful case and showcasing the nuances and difficulties in making a diagnosis. In every time, you are not able to make a diagnosis, but more important that how best you approach a patient and to a logical conclusion. Here, still, this patient is a wonderful case to showcase that point, that despite doing all the investigations, they're still waiting the etiological diagnosis. So keeping the options open, not doing all the investigations in every patient is very important. That we should develop our expertise, that which test will give me the most required information to take me a treatment decision. That should be our habit, and that should be our practice. Thank you, Ades and Satya, for a wonderful discussion. I think both of you have been excellent. Am I right, Dr. Tandon and Dr.
Yes,
Misra?
of course.
Yes, they are good students. They are hardworking students, and I didn't participate at all with them because I wanted to be fresh.
I mean, they're very spontaneous and very fluent, very fluent, and to the point. Not going around the things, but to the point.
Well done.
That's a wonderful, presentation by both of you. So many congratulations to both of you. Thank you, Manas, for again taking us through this case. Thank you, everyone.
Thank you, Govind, for spending your time in the afternoon every Sunday.
Yeah, and it's a privilege to be a part of ISG, Govind.
Certainly, sir. This has been a wonderful experience for all of us, and we know the power of the virtual teaching, virtual classes that we can take.
Thanks to COVID.
Whole country, and we have a faculty from each part of the country, and each faculty for last 11 classes have been superb. I think it has been a learning experience for me because I joined each one of them along with many other participants. So I learned the most probably from these classes. And we again welcome you for the next class or next master class next Sunday. I think we'll do one or two more before we close. The next Sunday, we will again wait for you for one other master class, same time, 11:30. So till then,
bye.
Have a great weekend.
Thank you.
Keep safe, keep healthy.
Bye.
Thank you, Vikas. Thank you, the tech team.
Thank you.